Okay, it's great. I'm seeing a lot of I'm seeing actually a few new people that maybe haven't been here before, or certainly don't have BIOFLEX, or maybe use light therapy of some other manufacturer, which is great. So today's webinar is on specifically about inflammation and recent research I want to share with everyone that I thought was really compelling, because it really speaks to having an alternative to commonly used medications. You know, we all are aware of the opioid crisis and so forth, but this is on a different level. These are medications that typically, you know, you just go to your drugstore or corner store, wherever it is, and you buy your ibuprofen, Aleve, Motrin, whatever, not really understanding the long-term effects of that. And now the long-term effects, other than the ones we kind of think about, you know, like GI or gut irritability and, you know, those kinds of things, there's actually some very compelling research now to really, you know, really think hard before you start taking these medications for the long-term potential negative side effects. And I'm going to share that with you today. And then I'm going to also talk a bit about phototherapy, or light therapies, different names for it, and what it can do with respect to inflammation and pain, obviously, and why it really is a better alternative than taking these medications. I really appreciate everyone letting me know where they're from. And if you're using BIOFLEX, if you haven't, just let me know where you're from, perhaps your name if you want to. That would be nice. And if you're using BIOFLEX or just interested in it, that kind of thing. If you're new to the webinars, or maybe not quite sure, the webinars are always recorded. So in the future, if you're interested in a webinar and perhaps you can't attend, then you can still register. And eventually, once we edit it, we'll send it an email with a copy of it so you can watch it again. They're also posted on our website as well, too, eventually, within a week or 2 weeks or thereabouts. So they are accessible even after the fact. But if you want a copy sent to you directly, then you just need to register so you can get on the email list. Sometimes that email list gets a little bogged down. I'm not sure why. And if you don't receive it, then just give me a little email and I'll make sure that gets out to you. So I'd like to introduce myself. My name is David Kunashko. I'm a chiropractor and I'm the medical director at BIOFLEX Laser Therapy. My background goes a long time now, over 30 years in practice. But even before that, I was involved in molecular biology, molecular genetics at University of Toronto. That's kind of where I got my start. And eventually, believe it or not, became a chiropractor, which is quite different than doing molecular biology research, I can assure you. But it comes in handy when trying to understand what's going on with this light therapy. So what I'm going to do today is specifically introduce our personal therapy systems. I always do that because I typically do one webinar a month that is a little bit more focused towards these personal systems, although I noticed the listeners are also professionals, which is great. The idea behind this is to give a good knowledge to the average person out there, but it's also really great for practitioners when they have to explain these things to their patients, explain how their light therapy is going to work on them, you know, these other types of tidbits of information or pearls of information that might be useful in clinical practice as well. So I'm going to talk about inflammation. I know, obviously, we all know about inflammation, but maybe a little bit more detail. And then I'm going to mention about NSAIDs and this breaking research that really was just published a month or two ago. And then I will definitely get into why light therapy is a good alternative to these NSAIDs based on the research. And then we'll always have time for Q&A. Any questions, type them into the Q&A box. I'll get to those at the very end of the presentation, if you don't mind. So our systems for home use look something like this. There are different sizes. The one's called the P120. It's 120 diodes, and the P180, it's 180 diodes. And oftentimes I get asked about, well, are these lasers? And if it's not a laser, people get all upset, or sometimes I do. And they get upset but I'm not sure I understand why, even though I tried to explain to them that this phenomenon of light therapy really doesn't matter if it's a laser diode or a light emitting diode or another source of light, as long as there's enough of that energy that's absorbed in a specific wavelength, pattern, and treated for long enough, and understanding how to use it. If all those things are in place, you're going to have a positive effect. Now, lasers are more effective in one way when you're trying to get light to a specific area, when you're trying to accelerate an injury, for example. You can do it with LED, it just takes longer. In clinical practice, lasers are nice because you can sort of blast away a little bit quicker. But what lasers miss typically is treating a large volume of blood. And that's really critical for inflammation. So I'm going to talk about that today as well. The equipment looks something like this. You can see these are actually LEDs. They're bicolor. So each LED emits two wavelengths, initially red, then near infrared. So one diode, two wavelengths. We're the only company that actually does that. It's really important too, because red is different than infrared. They're both effective in what's referred to as photobomb modulation, but there's differences. And if you do red before infrared, you'll actually allow light to go deeper into the tissues as well to some degree. And I'll mention that as well as we go along. The controller is quite easy to use. You can see that basically it has little lights that you click on depending on the area that you want to treat. It's anatomically based. And then you'll see that there's different treatment stages or levels of intensity and stimulation. There's a power, obviously, a pause function, a stop the treatment function, and select that stage function as well. So it's pretty straightforward to use by really anyone. I mean, we've had patients in over 100 that have used the system. So inflammation, is in the background of every single major illness. I came across this quote during my research for the webinar today, and it's really true. So what is inflammation? Well, when you think about inflammation, usually you think about, arthritis and joint pain, maybe an injury, that kind of thing. But it actually underlies most conditions that we try and deal with, right? Or our patients deal with, everything from diabetes and allergies and cardiovascular disease and cancer and obesity. There's so many conditions out there that underlying a lot of it is inflammation. So to reduce your inflammation, I'm sure everyone's heard about, inflammatory diets or low inflammation diets, that kind of thing. And to a large degree, that's really important in this whole puzzle. And I do advocate for that, although I'm not talking about that today, but that would be one piece of the puzzle. What we put in our mouth and eat is going to have an effect on inflammation. But there's other things that, that we can control as well, depending on how we actually try to treat the underlying cause of the condition. So, of course, we're aware of acute inflammation. Allergic reaction is one that comes to mind. But of course, trauma, you sprain an ankle, poof, it swells up and you have heat and redness and pain. That's acute inflammation. Everyone's been there, done that, and is quite aware of that. Chronic inflammation is a real problem, because acute inflammation should resolve on its own, should heal. You go to a therapist or a clinician, they help you deal with it faster. That's the idea. Why you would go to see a clinician is to get it treated faster, right? And there's lots of ways of doing that. But chronic inflammation can lead to lots of other long-standing problems, long-standing pain. It can lead to autoimmune issues. It can lead to cardiovascular disease, and I mentioned cancer. So it's not like, chronic ankle pain is going to cause cancer, but chronic inflammation in your gut can predispose to colorectal cancer, for example. So there's lots of examples like that if you want to live a long, healthy life, then if your lifestyle, if you change your lifestyle to reduce the inflammation, then this is very helpful. So inflammation is immune system's response to infection, injury, as I mentioned, and it's implicated in all these different types of conditions, even neurodegenerative conditions as well. The inflammation is actually beneficial, right? Because actually it leads to the removal of the actual damage or the chemical irritant or whatever that's causing the inflammation, and then it allows it to be restored to more of a normal type of tissue structure and physiological function. So that's the normal pathway of the inflammatory response. So the idea behind when you have inflammation is not to stop it, is to resolve it as quickly as possible in a natural way. When you stop it or block it, then you start to get problems. And that's what the research has shown. We've anecdotally known that, but the research recently has really indicated that this is what's actually going on. So during the acute phase of inflammation, there's a rapid influx of certain types of white blood cells. Specifically, these are called granulocytes, and the most common one, our most prevalent one are neutrophils. And then you get other cell types coming in that are called monocytes. These monocytes turn into a specific type of inflammatory macrophage, which again is a white blood cell. And it's a specific one. It's called an M1 phenotype. And I'm not gonna, it's hard for me to talk about this without getting into some kind of level of cellular biology and so forth. But end of the day, all you really need to understand is macrophages initially are, when you have an injury or inflammation, they start things going, they stir the pot. But then what's supposed to happen is this M1 phenotype macrophage will start to shift its phenotype into what's referred to as an M2 phenotype. And the M2 is what actually helps resolve inflammation, produces anti-inflammatory mediators, and clears everything up, and you get healed. So what you want to do is you want to accelerate the process along this way that I've just described, so that you start to get more of these M2s, and you clear up all the damage or the issues, and then you start to heal. That's what you want. So there are cardinal signs of inflammation that I'm sure everyone's aware of, certainly the clinicians listening in. You know, there's pain, there's heat, there's redness, there's swelling or edema. And sometimes I toss in loss of function, although there's really 4 cardinal signs. That's the first 4. And then sometimes I say 5, which is loss of function. So imagine you, I can relate to this, by the way, because I had some kind of hyperextension injury playing squash, and it really hurt. And so then afterwards, like, I had tons of pain. There was definitely some heat going on there. Some rubor, some redness, and I didn't have normal extension. So that's the scenario, right? Those are the cardinal signs of inflammation. Someone actually mentioned in the chat box if I've been avoiding any ticks. So I think I talked about I got a tick bite and ended up being negative for Lyme disease, for Borealis, but I got a little bullseye target rash, and that was an inflammatory reaction to that bite. I swear it was probably Lyme disease, but I went on prophylactic antibiotics right away. I didn't have any, it was stayed the size of a dime, but it was like a bullseye. It was clearly a bullseye, but fortunately, I don't think it caused any problems. So I've been a bit more careful being outside nowadays. So anyway, once the initiating noxious stimulus, which is a painful stimulus, is removed by something called phagocytosis, which is basically these macrophages that come in, and they're large white blood cells that engulf and remove stuff, and eventually inflammation can decrease and resolve. So I talked about the M1 and M2 phenotype of macrophages. So typically the normal outcome of acute inflammation is the resolution and its repair of tissue damage. When you try to block this artificially, i.e. NSAIDs, you may have some problems long-term. So failure of acute inflammation to resolve may predispose to even autoimmunity disorders, chronic inflammation, even excessive tissue damage. So to be honest, if you have an injury or an issue that has acute inflammation, I'm not recommending NSAIDs, even before the research came out. But for for those people out there that are not healthcare professionals, you know, it's not a wise idea just to start popping these things to give you some temporary relief, because you know, at the end of the day, what's going to happen oftentimes is it's going to lead to prolongation of the actual issue. So NSAIDs are obviously non-steroidal anti-inflammatory drugs. By the way, this webinar is not sponsored by Merck or any other pharmaceutical company. So I have no affiliation with Merck or the makers of Aleve or Motrin, obviously. You know, they're found everywhere, from cold medications, allergy medications, sinus medications. I mentioned, you know, Motrin, Advil, Aleve in the title, but there's many other types. Some are just different names for ibuprofen, you know, that kind of thing as well too. So lots of different types, but there's even some prescription NSAIDs as well too. You may have be familiar with indomethacin, may have been prescribed that. Celebrex had its day back treating chronic inflammation and arthritis. You don't see that prescribed as well as much now. Diclofenac, sometimes known as Voltaren. So a lot of these things you're familiar with. In the United States, that's prescription. In Canada, it's over the counter. What's going on? Like, what's going on with NSAIDs, and how do they supposedly work? Well, I mean, they do a certain blockage of progression of production of something called prostaglandin E2s or PG2s. Now, I'm going to try and explain this, but essentially what happens is you have a precursor called arachidonic acid, and this AA, as it's called, it will eventually form prostaglandins. And there's different types of prostaglandins, different types of PG2s, but these are considered the inflammatory prostaglandins that cause inflammation. Now, prostaglandins are good and bad. It's not like if you have prostaglandins, they're always bad. They actually help with normal homeostatic or homeostasis in cells, and they actually have normal functions. But when they get out of control or produce too much, then they can have these inflammatory negative kind of side effects. So it's prostaglandin 2s that cause those cardinal signs of inflammation, like pain, swelling, edema, and so forth. I know you guys are having questions, which is cool. Just type them into the Q&A box. Unfortunately, I can't answer them as I go along, because I want to make sure I get through all this material. So NSAIDs block this pathway, and that's how they work. So they actually block the cascade production of PG2s, which give you these negative side effects of inflammation, but they also help to resolve. So it's a double-edged sword, right? So they play a key role in the generation of this inflammation response. Now, prostaglandins are a hormone-like substance. They're not a hormone, but they're similar to it. And they are secreted by cells. And typically, they have a response locally, although they can also get into the systemic and the blood as well too, but it tends to be metabolized pretty quickly and easily. So you tend not to have a systemic effect with prostaglandins all that much away from the area of acute inflammation or inflammation that you're dealing with. So again, prostaglandins have homeostatic functions, and they mediate pathogenesis mechanisms of dealing with inflammation, including inflammation, right? So the apparent, and I quote unquote, clinical efficacy is such that it helps to supposedly block this sort of pathway. Now, the pain associated with prostaglandin production is quite complex, and I try to make some slides that talk about it. It's challenging because it's so complex, and lots of pathways and information that you may not be familiar with unless you studied this probably at a university level. But basically, what these prostaglandins do is can have an effect on peripheral sensory neurons. These are neurons that cause pain, as well as in your central nervous system, in the spinal cord and brain. And it can make them more sensitive to the sensation of pain. And that's why you have this pain sensation when you have a sprained ankle or an injury or whatever it is you're dealing with. So when you have high concentrations of prostaglandins, then you will have this direct effect on localized nerves, and then you'll have this pain. What they found is low concentrations of prostaglandins, so if it goes on for a long time but at low levels, it can increase your sensitivity to pain, and you can end up having chronic pain or chronic sensitization of your nervous system, such that you feel pain on a low level because it's in your spinal cord and the nerves there, but not locally in the tissues that's no longer inflamed acutely. So the pain threshold can be altered even if normally painless stimuli may be painful. So in other words, I'm not saying that really in a succinct way, but essentially, when you have inflammation, your threshold for experiencing pain is lowered and you feel the pain more. That's, I guess, what I was trying to say. So prostaglandins effect can be long lasting and it can be cumulative. So that continued production of even these small amounts can sensitize your nerves. And as I mentioned, the central nervous system, like your spinal cord and your brain, start to become involved as well. So there's two ways that it's affecting pain. One is locally and one is centrally in the central nervous system. Okay, so that's a lot of the science stuff. It's hard for me to talk about it without getting into a little bit of that. So hopefully that was understandable to some degree. Now, in May 2022, this year, the media outlets started to report about new research that was published in part by McGill University in Montreal. And the title of the paper was Acute Inflammatory Response via Neutrophil Activation Protects Against the Development of Chronic Pain. And essentially, the next few slides are going to talk about this research because it's really quite important research. They make a point of saying chronic pain obviously inflicts a huge cost to society, and we all know that. And specifically, they were targeting low back pain, and to some degree, they even looked at temporomandibular joint pain as well. These are the two areas that they focused on, but end of the day, you can have chronic pain in lots of different areas as well. The stats were it's the most frequently chronic pain condition that's reported. On a 1 month and 1 year prevalence, it's anywhere from 31 to 38% of the population. So it's really high. So low back pain ranks the highest among all chronic conditions in terms of years lived with a disability. It increases in prevalence as we get older. So, everyone, I'm sure, is in some part thinking about or are taking Aleve, Motrin, ibuprofen. I mean, look at the ads, right? You show some guy or some woman with back pain, they're bent over in pain, and then, oh, Aleve to the rescue, right? Aleve, or Motrin, or whatever it is, right? And I'm sure the makers of these drugs weren't too happy to hear about the research. Not that they won't continue to push their NSAIDs. The problem is very little is understood about the molecular mechanisms as to why acute pain turns into chronic pain. And there's increasing evidence that suggests what's referred to as a pathophysiology of chronic pain is a very complex interplay between the nervous system and the immune system. And so chronic pain is considered to be a neuroinflammatory disorder, and it's mediated by both the neurons or nerve cells and other cells as well, like these immune cells, white blood cells I talked about earlier, like neutrophils, monocytes, and macrophages, and I've already mentioned that earlier. So these play a critical role in that. So activation of these cells results in the expression of various inflammatory mediators, like we talked about, like prostaglandins and the proteases. There's lots of other ones, and they act directly on the peripheral sensory system and the central nervous system, as well as other immune cells and local cells, and they help regulate pain. There's also other specific types of cells in the central nervous system that act very similar. And if they're continuously irritated, it can lead to this central sensitization and chronic pain. So the presence of these activated immune cells and glia, which are similar in the central nervous system, both in the peripheral nervous system and the central nervous system, are thought to contribute to the transition from acute to chronic pain. So the researchers investigated, the research was was really fascinating, and I can't get into all the details because it was, even I was having a tough time trying to sort it all out. But they investigated the molecular pathophysiological mechanisms of peripheral blood immune cells, so white blood cells, that underlie the transition from an acute injury, and also now you have chronic issues, and specifically in low back pain and also temporomandibular joint pain. And they identified the protective effect of acute inflammatory responses against the development of chronic pain. I'm going to say that one more time. The researchers found there is a protective effect of the acute inflammatory response against the development of chronic pain. What that means is that acute pain, when you run through it and it resolves through a normal process, it's going to protect you from developing chronic pain. It's when that process is not resolved or blocked, leads to a higher percentage of development of chronic pain. So they looked at low back pain, they looked at temporomandibular pain, and the results suggested that active inflammatory responses, particularly those regulated by neutrophils, remember those are the granulized white blood cells I mentioned earlier, contribute to pain resolution. They hypothesized that the inhibition of this immune response, that is taking NSAIDs, will lead to the prolongation of pain. So what they found was that, and again, they did a whole series of really complex genetic studies. They found that individuals with acute back pain, okay, so picture this, you bend over or you do something or whatever it is, you wake up in the morning and all of a sudden you have acute back pain. We've all probably had it, can't put your sock on, you're bent over, you know, I'm a chiropractor, you see it all the time, right? And there was almost a twofold increase of developing chronic back pain if they reported taking NSAIDs. So think about that. Doctor says, just take Aleve, take ibuprofen, rest it up, and you'll be fine. But that increases the probability by 2 times development of that back pain never completely resolving, always being there and developing into chronic pain. And they adjusted, by the way, for ages of the patients and male, female, ethnicity, all these types of things as well too. So their data suggested that active biological processes protect from transitioning from chronic pain after an acute pain episode. In other words, let your body do its thing. They found that neutrophil activation, I talked about that earlier, a dependent elevation of inflammatory response at the acute stage of pain in subjects with resolved pain, which was decreased by the time of the second visit. So in other words, that if they let it naturally continue, that they started to see this neutrophil influx start to decrease and resolution of the pain. But in patients that had persistent pain, they did not show these changes of the inflammatory response. In other words, they didn't see the neutrophils start to decrease. They didn't start to see the monocytes come in. The macrophages turn from M1 to M2 to help clear things up. So they didn't see that in patients that were taking the NSAIDs because the pathway is being blocked artificially. So the research suggests that the active immune process, that is your normal body response, confers adaptation at the acute pain stage and impairment of such inflammatory responses. So in other words, prolonged use of NSAIDs can kind of block that and then increase the risk of developing chronic pain. So these adaptive inflammatory responses can be inhibited not just by steroids, but other medications like NSAIDs, not just NSAIDs, but also medications like steroids as well. So despite the analgesic effectiveness at early time points, the management of acute inflammation may be counterproductive for long-term outcomes of low back pain and other painful conditions like TMD, and I'm sure other ones as well too. So let's going to back up a bit there. Let's back up there. So basically, what they said in this research was that we need to rethink the way that medications, now they're talking about medications, the way they should be used and prescribed or recommended. So really what they're saying is that NSAIDs is probably not a good choice for acute pain. They actually said, well, maybe there's other medications or whatever. And to be honest, they probably should have said, well, maybe there's other ways of treating it with therapies or non-pharmaceuticals, but probably, that's medicine, right? They're looking for drugs. But there's other ways of dealing with inflammation and helping it resolve in a way that's more effective, and in fact, probably much safer and less prone to form chronic pain. So I'm going to, I'm going to go overtime for sure. I'm going to go about 10 minutes overtime so everyone's aware. A few pieces of research I want to share with you to explain why light therapy is effective. This first paper looked at and compared what was then known as low-level laser therapy. Now it's referred to as photobomb modulation therapy. And they used two different dosages. So they used 1 joule of energy and 3 joules of energy. And they compared it to the use of Motrin, which is diclofenac. Remember, that's an NSAID. And they want to see which was better at reducing the cardinal signs of inflammation in acute tendinitis. So that's what they were doing in this experiment. So what they did was they injected an enzyme called collagenase in the tendons of rats. Some of them had no injection. And then they were treated with either laser therapy, 1 joule or 3 joules, infrared light, or they were treated with a diclofenac sodium or Motrin. And they over time, they looked to see what changes were occurring in the actual inflammatory process. So this is a normal, healthy rat tendon. You can see it's glistening white. By the way, if you've ever watched my training, I talk about this research as well too, because it's so visual. I really do like it. Normal healthy tendon. Now, if you inject it with collagenase, or for example, a better way to think about this, if you're a runner and you decide to go up and down hills a lot or on a terrain that you're not used to, and you develop acute pain in your Achilles tendon, for example, this is what it would look like. It becomes swollen, boggy. If you looked at it, it would become yellowish, and on the outside of the skin, there'd be redness and some swelling, right? So that's what an acute inflammatory process looks like. When treated with diclofenac sodium or the Motrin, after I think it was 7 days or 5 or 7 days, they excised it and looked at it, you can see that there's not a whole lot of change. It's still actually pretty swollen, and the cardinal signs of inflammation still appear to be significantly present. When used same time frame with 1 joule of infrared light, now it was a laser in this case, but again, doesn't matter. You can see that the tendons almost completely resolve back to normal. So again, cross comparison, you can see that light therapy is more effective when compared to an NSAID to treat Achilles tendonitis. Now, what's really fascinating is that if you use too much light, there's not much change. And the reason why I mention that, and it's really important, is that I don't know how many people I talk to on a weekly basis, and they ask me about why can't I just buy this device, or what about Juve and this and blah, blah, blah. And there's tons of stuff out there. And admittedly, some of them will work. A lot of them will work if you know what you're doing. But if you don't know what you're doing, and if you don't understand the dosaging, and you don't understand what the dosage is coming out of your equipment, all these different factors, then you might not get the results that you want. And then you say, well, light therapy doesn't work. Well, unfortunately, that's not true. It is going to work, but you need to get the correct dosaging, because if you have too much dosage, it's not going to work. And if you have too little, by the way, it's not going to work either. So one of the things that we really focus on with our equipment is that we have been doing this for 30 years. We have developed, treating tens of thousands of patients to have a better understanding of dosages and parameters that are going to be effective and give ranges to be able to work with. We know they work. And that's a big factor of why I feel what we do is going to be effective. Now, another paper, this one seems pretty complicated, but remember earlier I mentioned about the M2 macrophage, which is a good macrophage, right? That's the one that comes in and helps to resolve inflammation. So this research looked at M2 with respect to photobomb modulation. So remember, M1 and M2 macrophages. M1 is what first comes in when you have acute inflammation, and you can see here its function is pro-inflammatory. Okay, it can also lead to tumor activity, tissue damage. It's not the one you want hanging around in your tissues. You don't want this phenotype of the macrophage that's initiated because of all the chemicals released during inflammation. You want this to turn into M2 macrophage, which is anti-inflammatory, helps with tissue regeneration, repair, phagocytosis, which is cleanup, angiogenesis, new blood formation or blood vessel formation, immunomodulation in a positive way, those kinds of things. But there's always a balance, right? If you have too much of the M2, then it can also lead to negative effects as well. You need a balance, but you need it shifted as well. So that's the significance of M1, M2 again. And again, just another little picture here to show you M1 and M2 can go back and forth depending on the needs of the tissue. But if it's excessively M1 for too long, you get too much pro-inflammation. Whereas when it's shifting to M2 and predominance of M2, you're going to get more anti-inflammatory and resolution, and that's what you want. So what they found was photobomb modulation. In this case, they used LEDs, that it upregulates genes which indicate a polarization of macrophages of M2 phenotype, contributing to tissue repair and resolution of inflammation. Basically, I'm just trying to tell you that what they found, the research is that photobomb modulation light therapy shifts M1 more to M2 to help resolution, not blocking, but resolution of inflammation. And that's what's really important here. Okay, another piece of research, is LED or light emitting phototherapy really effective? Okay, so that's a lot of stuff. I only need you to focus on 4 things here. One is you use photobomb modulation. Don't worry about all this other stuff. What they found is that if you use photobomb modulation, it can accelerate wound healing, it can accelerate the inflammatory response, that is, help to resolve it, and it can help attenuate or reduce pain through a whole series of reactions. This, I thought, was a great diagram because it talks about all the different things that are going on in photobomb modulation. You may or may not be interested in it. If you are, it's a great picture to look at if you understand, all these different factors. But end result is that's what's going to happen. And that's why it's so effective. It's not blocking arachidonic acid. It's actually helping inflammation move along, giving it a kick along the way and helping it resolve. So that's what it's doing. Why you would use BIOFLEX, I mentioned it earlier about what we've developed, but end of the day, what's really important with our personal systems and or our professional systems is that we treat a huge volume of tissue with blood. And this all talks about white blood cells and blood. I'm not talking about treating a muscle injury. I'm talking about treating inflammation. And if you have a small little device or just treating a small area, or you don't have you're not treating a large volume of tissue with enough light, you're not going to promote this really important, even though I'm going to say anti-inflammatory, it's really a pro-inflammatory response because it accelerates inflammation. So, our equipment is designed to treat a large volume and the diodes are spaced really close together. So you're getting a lot of power density or energy density, I should say, into the tissue. When you release red light, it only goes superficial, but the photoacceptors are targeted in such a way that allows when you then use infrared to go even deeper. So sequentially using red and infrared allows light to penetrate to some degree to go even deeper into even more of the volume of tissue and especially the blood. So the idea here is you're promoting these chemical effects by resolving and accelerating inflammation. So end of the day, whether you have a very first generation LS array that was red and infrared, someone emailed me earlier about that, the effect is the same. If you're already using a system then I would say that you need to understand exactly I'm not saying you're not getting good results. I'm just saying if you really want to make sure you're getting the best results, you need to really understand dosages. You need to understand the tissue you're affecting and so forth. Our equipment just makes it a little bit easier to do that because we have proprietary protocols developed. We have the way the system works is to treat a large volume of the blood to promote this type of effect. I hope you enjoyed today's webinar. I do have a few coming up. One is on treating muscle strains. Then I'm going to compare panel devices, LED panel devices like Juve and all these ones that are promoting red light therapy by standing in front of, a big LED panel with your underwear on, or sometimes even your clothes on, which is bizarre. And I'm going to talk a bit about why these panels may not be as effective as they really should be or could be. And really, it comes down to the fact that all the research indicates that you should touch the skin to the diode, all of it. All of it. So if you're not doing that, you're not following the research. And I really follow the research. So I think it's important to understand why photobomb modulation is effective. It's effective if the light gets into your body. And then I'll talk a bit about specifically for massage therapists, and why we're seeing a really large number of massage therapists starting to use light therapy in their practice. So if you're a massage therapist or a no massage therapist and they don't use light therapy, or even if they do, that would be a good webinar to attend as well. I'm doing a Let Up Your Practice, which is mainly for clinicians. This Saturday, I do one every month. So if you're interested in your clinician, you can sign up. I think it's just $99 Canadian, which is probably like $20 US or something. I don't know what it is. So there's still time to register for that. Saturday, it's only 3 hours, 9 to 12, and going into more detail about photobomb modulation. There may be some questions. Oh my gosh, there's a lot. So let's see here. I have a question about glaucoma. Lynn, that's a great question. Actually, they're doing research, and we're involved, not with glaucoma, but could be glaucoma. I can't remember now. Randy Santiago, our clinical research director, is starting a trial in the Philippines for, I think it's macular degeneration actually, but our equipment is not designed for this. So I do not recommend you do that, but there's research indicating that it might be very helpful for these eye conditions. Question about application for post-stroke. I've covered this before, and it can be used for post-stroke recovery. Still a lot to learn on that effect. To what extent on a scale of 1 to 10 might red and infrared light be effective for reducing dental abscesses until dental treatment can be performed? Yeesh. Okay, so I mean, we're talking about an inflammatory bacterial infection. So I'm always going to say, get the antibiotics going and get to see the dentist. This wouldn't be an appropriate treatment. It might help with some of the symptoms, but it's not going to resolve the underlying infection. Is there compelling research on the long-term use of steroids such as prednisone causing inflammation? I'm wondering if PBMT would reduce the need for steroids. Well, by the way, they did mention steroids as well in that research. So, but they focused more on NSAIDs. So I'm pretty sure that you could probably lump that in as well too. A question about if the personal assistants can be used to prevent neurological degradation and improve memory with regular use, and could it be helped with reproductive systems like infertility? Okay, I'm going to say this. Perhaps. So there's compelling research to show that it may help slow down cognitive decline in the brain, along with all the things you should be doing with cognitive exercises. If you don't know Norman Deutsch, read his books, DOIDGE, on neuroplasticity to learn a lot about the stuff that you can do. He was a guest speaker at our masterclass a few weeks ago. For infertility, there is also research to indicate that it may help reduce inflammation, which can cause infertility. Again, experimental, we don't really do it, but some practitioners are. Can overuse of NSAIDs be reduced by stopping using them? I'm not sure I really understand that. Oh, the damage. Oh, you know what? I'm not. So yeah. So if there's damage done, like chronic inflammation, let's say chronic inflammation, um, I would think your body would be able to slowly resolve that, but that becomes more challenging. When it comes to the side effects of NSAIDs, like GI issues, that kind of thing, again, I think the body has capacity to heal, but it all depends on the extent of the damage and that kind of thing as well, too. A question about headaches and chronic headaches and BIOFLEX. I mean, we treat headaches all the time, and headaches are challenging because there's so many causes. So it really depends on the cause. Sometimes it's multifactorial, but basically treating the neck and the upper neck and the occipital region, those kinds of areas, we do find that it's helpful, but it really depends on the cause. A question about using ASA for low dose ASA for cardiac prevention. Unfortunately, I'm not an expert. I'm not a physician, number one, and I don't have the wherewithal to recommend that. Other than my own doctor said, I used to do that, and my own doctor said that's not what the current research reflects. So I think it's more of a preventative, or if prescribed by a doctor, but it used to be common to take them as a preventative, but I think now only in certain cases. Thanks, Kim, and Kim and Dr. Kim and Pierre listening out in beautiful Vancouver. What is the user interface for both personal systems, touchscreen or buttons? How about the therapist system interface? The interface, Jade, is so it's like it's a touch button or touch screen. And I'm not sure if Jade, someone mentioned they had a visual impairment. I think you'd still be able to use it, to be honest. If you're totally visually impaired, then you'd have to have someone show you, where the buttons were. But it's not that difficult, I don't think. But I've never come across that. But to be honest, that's a good point. So and the therapist system is more complex because you visually have to see the screen in order to use that one. A question about multiple sclerosis. Hi, Dr. Bradshaw. The MS research is very limited. There's a bit out there, especially on mouse models, indicating some efficacy or experimental efficacy. We've seen some interesting results, positive results, but too early on and not enough research to really say much. But I would try it though. How would you treat the whole body inflammation? So if you're trying to treat systemically, you got to think about so here's what I'd recommend. I'd recommend treating over your gut, your abdomen, and treating behind your knees. Behind your knees is lots of blood there, and you can get light into your blood a lot by treating there. I've talked about this before in some webinars. And your gut, treating directly over your abdomen would make sense because your gut's a huge source of inflammation. And if you reduce inflammation in your gut, you're going to reduce cholesterol levels, you're going to reduce cardiovascular disease, you're going to reduce chance of colorectal cancer, all these different things. And this is just not me being some kind of, alternative medicine kind of guru. It's pretty much factual, that inflammation in the gut it leads to lots of problems. So I think that's pretty well understood. Question about frozen shoulder. It definitely helps with frozen shoulder. We've seen tremendous results with that. Long COVID, I haven't treated many, but I know Dr. Ashley Banjan in South Africa, in Durban, has, and he's had good results, along with some of our other practitioners as well, too. The main difference between the personal systems and the professional systems, really the main difference is that there's a full complement of software with the professional system to be able to alter every parameter used, as well as There's a class 3B laser probe with it as well. That's really the main difference. And of course, the way they're designed and made to be used every day, 8, 9, 10 hours a day, it's comparable to like a professional grade, whatever, to a consumer grade, whatever, right? There's going to be differences there because consumer grade isn't meant to be used, on hundreds and hundreds of people weekly, that kind of thing as well too. Last question, is using NSAIDs for chronic pain, example, severe menstrual cramps, just as problematic as NSAIDs for acute inflammation? I would say, yeah, I really would. If you're interested in helping with menstrual pain or dysmenorrhea, give light therapy a try. There's actually really good research to show that it can be very helpful. There's 2 major acupuncture points you can put it on, or just over the area. I would definitely say that would be at least try that option, because I think the research is compelling that although occasional use of NSAIDs isn't going to cause this problem, I admit it, more than likely, but chronic use may well do that. Thanks everyone for joining me today. I do appreciate your time, and we'll see you next time. Thank you.